Hi, I'm Sandra Barrington, and welcome to Doc Talks. I'm the Executive Director of Sierra Nevada Memorial Hospital Foundation, and Doc Talks is a series where we bring local physicians to you to learn more about their educational background, how they became a doctor, what services they provide in this community, and a little bit about what they see as the future of healthcare in our community. And today I have a very special guest with us, and it's Dr. Clayton Hess. He is in radiation oncology at the Sierra Nevada Memorial Hospital Cancer Center. Welcome, Dr. Hess.
Thank you for having me.
We're so excited to have you here. Our cancer center is a shining star of our hospital and such a special place where people come for their treatment and their recovery and their journey, really treating the whole person, the whole family when it comes to a cancer journey. So thank you for the incredible work that you do with our patients. So tell us a little bit about your educational background and what it took to get to where you are now.
Well, thank you for having me again. I've hopscotched around the country a bit. So I have been East Coast, West Coast, Mid-Coast. Not a thing, but you get what I mean.
Yeah.
Most recently, I came from Atlanta, Georgia. So prior to coming here, I was an assistant professor at Emory University in Atlanta. And prior to that time, I spent 3 years in Boston at Mass General Hospital.
Wow.
While I was there, I completed a fellowship, kind of refining the radiation oncology skill set. And then I received an NIH grant there to study circulating tumor cells in childhood brain cancers, actually.
Oh, wow.
Yes. So, and prior to that, I had been at UC Davis, and that's kind of the Northern California connection for me. I had done my medical education at Penn State prior to that and did an internship at the University of Texas in Austin. So that's kind of going
You've been all over the country.
all over, yeah.
Are you originally from Northern California?
I'm originally from Southern California.
Okay.
And so we would always come up to Northern California, always went to Yosemite as I was growing up, did a lot of my Boy Scouting in the region, so fell in love with the mountains, always wanted to return back to the West Coast. And as a radiation oncologist, that's a hard thing to do sometimes because they're quite competitive positions, and it's always hard to kind of find the geography that you want.
So what made you choose radiation oncology as your specialty in medicine?
So radiation oncology is a unique blend, right? On one spectrum, you might think, reading radiographs or MRIs, that's really what diagnostic radiologists do, and their day-to-day is, I'm behind a screen, I check one film after another, and there's very little patient contact for most radiologists. And then on the other spectrum is you have oncologists, where specifically medical oncologists, where they're treating cancer, but it's not a very technical field. Radiation oncology blends those. So it is very physics heavy, where we're talking about photons and gamma rays and all kinds of confusing, words that most folks don't, they're not familiar with.
My degree's in English, so that's,
Yeah, my degree is also in English, right?
Really?
Well,
Wow.
I had an English emphasis, but at least undergraduate. But it is a unique opportunity to combine the complicated and simplify it, right? To hybridize that which seems too complicated to understand and really harness something that seems dangerous, but is actually very strategically useful in annihilating cancer.
Okay, so in our cancer center, we have Dr. Hung and Dr. Campbell on the oncology side, and then we have Dr. Hess on the radiation side. So maybe tell everyone a little bit about what services are different on each side of that cancer center.
A great question. So Dr. Hung and Dr. Campbell work very closely with me, and we're all targeting towards the same goal. So as an oncologist that specializes in radiation, they're oncologists that specialize in chemotherapies or immunotherapies. Anything, you can think of it like potions from Harry Potter, right? So they do the potions, right? And I do the aiming with the beams.
Okay.
So we're overlapping like a Venn diagram.
Analogy, by the way. It's a great analogy.
If we go back to elementary school and we're talking about those old Venn diagrams, like where do the circles overlap, right? So we overlap in our goals to cure cancer, but it's the tools that we use that are different. So if we just have, an example patient, someone comes in with breast cancer, right? Then they're going to need a surgeon to cut it out. They're going to need a radiation doctor to mop up the cells that might be left behind. And they're going to need a potions master, right? Someone to give anti-estrogen or some other drug in order to keep it from returning as well. So we really blend our tool chest to optimize each patient's care.
That's great. Yeah, and like I mentioned before, the whole concept is treating the whole person. So on the medical side, we have that whole person care, but we also have some support groups within our cancer center that help support the patients. We have a Writing to Heal program. There's a heart program. We have a meal program called Comfort Cuisine. So maybe touch a little bit on that holistic care and what it takes to really take care of the whole person.
That's a great point. In addition to the support groups, right, so there's the mental component, right? There's going to be distress when cancer is found. When you discover it, it will change your goals. It will cause you to grieve. There will be a loss of expectation, let alone bodily function. There will be fear and anxiety, and that mental component is important to address. So for that aspect, Dignity Health combines with other centers regionally into what's called the Greater Sacramento Dignity Health Cancer Institute. And that provides psychological support where we have access to a psychotherapist that's specific to distress for that component. So from a holistic patient, you basically just take a person and divide them into each of the categories. So that's an important component. The support groups are phenomenal in terms of being able to pair someone who has been through the process, has written their own journey, and pairing them with someone who's brand new on their journey. So that really enables folks to talk. And from my perspective, what I often hear is something like this. Hey, I found 3 buddies. They all have the same diagnosis as me, just taking a recent prostate cancer patient in the back of my mind as an example. And they said they experienced this and this and this. And so I got a good flavor about what it's going to be like. That's been really invaluable, right, to be able to give patients an expectation, right? Because I'll go through it and give like the statistics. It's likely you could have this side effect or this side effect. And we roll that into like a decision. Right? Should we do it? Should we not? How much? How long? And we really individualize in that way. Beyond those categories, there's a host of others even you haven't mentioned yet, right? So there's the nurse navigator who's going to help you navigate the whole system. There's going to be a nutritionist to help manage your diet. There's going to be a speech and swallow team if any of the swallow apparatus is involved as well. And essentially a host of other layers of protection and layers of support that will help round out just the cancer treatment itself.
That's amazing. So a really multidisciplinary approach to how you handle.
Absolutely,
practice,
right.
yeah.
At the physician level, because we're always meeting with each other in committee, and also even beyond that to the support level as well.
Great, that's wonderful. So what would you say is the most prevalent type of cancer that you see in our community for our patients?
So the most common kind of cancer is skin cancer. It's so common they don't even count it, right? If you go to the cancer websites nationally, they don't track it because there's really no way to do it because dermatologists everywhere are handling it. So we're focusing our attentions on skin cancer increasingly to be able to offer operative treatments, resection or Mohs surgery, and also non-operative modalities where radiation can actually treat skin cancers without leaving a scar.
Oh.
Just to mention, but so skin cancer is the most common. Among those that are tracked, then breast cancer for women and prostate cancer for men come in as the next most common. And those can often be treated with very good success provided that they're found early. So, of course, it speaks to the importance of screening.
Yes, definitely.
And I would round out that short list with lung cancer, which is...
We've been talking about that recently, of how we can increase lung cancer screenings in our community, because when it's typically when someone finds a lung cancer, it's a later stage, correct?
And that's right, because it's very common to grow without telling you, right? It's kind of sneaky. It makes no pomp and circumstance. It just grows and you're totally unaware. So many folks will say, how could this have been there? I didn't feel anything. And it's because it's not obligated to tell you, right? And so lung cancer screening is probably the highest yield screening modality, simply because even though lung cancers are maybe the 4th most common, after after prostate and breast cancer, it is by far the most dangerous cancer.
And we talk a lot about breast cancer screenings and having your annual mammogram. We talk about prostate screenings, and I'm sure that's something people commonly think about. We hear a lot about it in the media. But someone who may be concerned about lung cancer, what would be their next step? What would they say to their doctor? How would they get a screening if they were concerned for it?
Yeah, so there have been studies that have shown that if you screen with a low-dose CT scan once a year, then you're going to be more likely to cure a cancer that you find compared to prior screening methods where you just used a chest x-ray. So federal guidelines are now recommending that, and I'll be hesitant to kind of set the threshold because they're ever changing and even recently did, but essentially if you've smoked a certain amount and if you've quit within a certain number of years, then a CT scan once a year might be your ticket to avoid, that catastrophic reality of I have lung cancer and it's not curable, or that the chances of it taking life are unacceptably high. And if there was one screening test that I would say would be the most protective for a smoker or a former smoker, it's going to be a low-dose screening CT scan once a year.
And that's something someone could ask their primary care about and say, I need a referral for
Precisely.
a screening. Great. Well, please do that if that falls into the category of your life, because it could help save your life. So curious what you think. You mentioned the regional cancer centers. There are other cancer centers around Northern California. How would you say Sierra Nevada's compares to other cancer centers?
Yeah, so Sierra Nevada, we have a proud reputation that we're building on, right? So when I arrived and heard about how things had been prioritized from a cancer standpoint, it was clear that cancer care had been uniquely built and well built, and that kind of the ground that I would build upon was a sure foundation, right? And so we've been very proud of that. And my efforts to build and further enhance and improve have been really only made possible because of the good foundation already established. So we already have tumor boards regionally. We have good coordination across providers. We have access to those tumor boards at the regional level if we need expertise that isn't here regionally or locally. And overall, it compares quite well. Are there stars for us to reach to? Of course there are, but it's a good program, good care, and I think reliably the feedback is this care is just as good, if not better, than what I can get elsewhere because it's close to home, it's personal, we know your name, we know where you live, and we can provide the care to the same caliber as can be provided down the hill.
Wonderful. I was actually touring a group through the Cancer Center recently, and one of the linear accelerator techs was talking about that technology, and I asked the question. I said, how does this compare? What do others have? And he said, well, I used to work at Stanford, and we have everything here that Stanford has. And I thought that was really great coming from an employee that's worked at other cancer centers.
Yeah, I would agree. There are very few reasons at present to send people away.
Wonderful. Because, at the Hospital Foundation, one of our goals is always to keep people local for their care and focus our projects on how do we increase access to care. And so that's why the Cancer Center is one of our focuses regularly. So for the future of your specialty in our community, what do you see as the future of medicine and radiation oncology?
Oh, big question. So I think for oncology, there's many, but one I would like to highlight is a shifting paradigm of what it means to live with cancer. Historically, for decades past, there's been this paradigm where you either cure or you don't. And it's either good news or awful news. But that is changing. The more and more drugs or potions that are available, they're actually getting quite specific, where they're able to target individual kinds of cells with fewer side effects. A second mentality that we're changing is essentially going into attack mode. If someone has metastatic cancer, that person could very well survive for years. And it changes it from kind of a doomsday situation to a let's manage this together. Nobody really is too distraught if they're told by their cardiologist that they have incurable heart disease. Because it's always incurable, right? It's just something that happens with time. And as our cells age, some of them go rogue. So with advancing age is a higher risk of cancer. But what we're doing is by spot welding, meaning shooting and hunting the cancer nodules that might grow in the body, as well as adding in the potions that have fewer and fewer side effects, we're able to see people living longer with metastatic disease, where the goal is just to keep it at bay, keep it retreated and not attacking. And that allows people to live with these cancers without really knowing it.
Well, that's wonderful. That's a very hopeful outlook for the future of cancer care, especially here in our community with our aging population.
It is indeed, and a lot of people have vocalized to me their surprise, right? That the shock and awe of not being able to cure something is kind of not as it once was. And while, of course, that doesn't mitigate the danger and the need for vigilance, it has been quite hopeful to watch patients kind of go month after month after month. No recurrence, or it only recurred in one spot. So we switched the potion, shoot at the area that grew, and on they go with their favorite task or hobby. So it's really changed the game on what it means to live with metastatic cancer.
Wonderful. Well, thank you so much for joining us for Doc Talks. It was great to have a chance to chat with you. You can find us online at supportsierranevada.org/doctalks and also on Nevada County Media's website.